Welcome back. So this is part 3 of 3, and today we're going to talk about behavior, which, if you follow them in sequence, you've already watched communication. And I want to make a point that behavior, in many ways in dementia, behavior is another form of communication. So try to think about behavior as, in your interactions with your person with dementia, as ways of their being able to communicate with you in different or more subtle ways, which becomes more and more important as their language diminishes. So just to review a little bit, Alzheimer's and other dementias are progressive diseases. They're progressive diseases. Things are going to get worse, not better, and it's best if you prepare as much as possible by educating yourself and doing things like watch this video and study the material. Remember that the main problem that the person with dementia is experiencing is that they have two things going on at the same time, both short-term, especially in the beginning phases, short-term memory loss, eventually also long-term memory loss, and the lost ability to problem solve, to add a list of numbers. And so in combination, poor memory and problem solving become a particularly difficult series of a combination of issues and problems. So let's see.
I'll add something. That everybody goes through this disease differently. There are many forms of dementia. Alzheimer's is only one form. And even with that, people go through the disease differently. So don't ever compare your experience to your neighbors, because if you listen to just the banter of the community, sometimes Alzheimer's gets a bad rap or dementia gets a bad rap, that everybody is agitated and combative. And certainly we know that that's not true. There are unique and specific problems that seem to occur depending upon the person's own personality. So it's really important, however, not to take the behavior personally. As a caregiver, you are the one person that I use the analogy very much like a parent-child relationship, where your child might test you as the parent, seeing where the boundaries are, and you're ready to pull your hair out, and then your neighbor says, "Oh my, are you Johnny's mother? He's such a wonderful boy." And you're like, "My Johnny? Are you kidding?" You know so it's unconditional love. You're the one person that is the target. And we know you're doing the very best you can. So please don't take it personally, and again, find a support group or call us if you need to release in some way or be supported.
I think it warrants also just going back for a moment and just reviewing the idea as well. Thank you, Suzanne. That was a really good point, a couple of points. Also, keep in mind always that there are good days and bad days, and that there isn't a downward only trend, that you'll even question maybe at times whether or not you've maybe made too much of a fuss about this, or maybe they don't really have dementia, they're having such a good day, or maybe there's something else wrong because they're having such a terrible day. So what's normal about dementia is that it's fairly unpredictable. And so despite what you know and what you'll know at the end of this class, it'll also be full of surprises. So, and that means that the change that has to happen to improve communication and to be on top of the behaviors that will happen is that the change has to happen both in the person with dementia by setting limits with them, or seeing that things are set up more easily for them, but also change has to happen in we as caregivers. So there's has to be change on both parts. So we're going to talk about some common personality changes that you're going to encounter because changes in personality is part of the journey. And Suzanne, do you have a preference where we start? Do you want to?
Well, I think we can just go down the list, and as we have examples, we'll be more specific.
So the first one is becoming more upset and angry more easily, having less tolerance for just change. There's a saying that I like to remind people that's very helpful in dealing with dementia is that routine is supreme. That if you can keep things as much the same as possible, that's going to be really helpful both to you and the person with dementia, but especially in the world of dementia. If it's predictable, then that's a really good thing. You sometimes inadvertently think that you're going to give the person a break, or that it's going to be too boring, or wouldn't it be wonderful to get away? And then all of a sudden you find yourself on a trip or moving things around, and they can't find where the silverware is or whatever it might be.
Yeah.
So,
and that happens quite frequently, particularly on the Cape, where we have a lot of population goes to Florida for the winter and returns in the spring. And in the spring, we get a rash of calls from people who have perhaps lived in their home 20, 30 years, and suddenly the person with the dementia can't identify their surroundings, and the caregiver wants to know why. So again, it's generally change in routine, and what is not familiar after a few days is certainly not familiar after a few months.
Yep. One of the things that I hear in my support groups a lot from caregivers is that there are periods where they feel like their loved one is isolating more and more, withdrawing from society, from them, from their relationship, from the desired kinds of activities that families might have. They might not want to go to a Thanksgiving dinner where there's a big gathering, for example. And isolation, being withdrawn, not is particularly interested in new activities especially, is something that you're probably going to see a lot of. And that's part of the personality change that is fairly predictable and something that you can prepare for.
And that becomes hard for the caregiver, because you may be a person that's very social and want to go out, and there will be a point within the disease progression where you have to determine whether it's safe enough to leave the person alone, or conversely, whether leaving them alone creates more anxiety for them because there's nobody there to sort of ground their day-to-day experience.
So notice we're not giving you exact directions or specific instructions on how to handle your particular case, because it's got to be done on a personal basis. It's got to be done one-on-one, and it will probably be different next season or next year, the kinds of approaches that you take. So I think misunderstanding and misinterpreting what's seen and heard in conversations, even about the thing we're talking about here, can often be very, very frustrating for caregivers because of the change that I just talked about, that the fact that the disease is progressive, that over time they're going to get less and less able to follow the chain of the conversation, and they won't necessarily always be able to understand the words that you're using or the references that you make very casually about, our son Charles, who blah, 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 whatever. And they're not able to figure out that Chuck is actually Charles, and that he's, whatever, no longer a teenager, he's a grown adult, etc.
This is a long segment, so I want to make sure that we also make the point, and we go back to, I'm a psychiatric nurse, dementia specialist, Alan's a social worker, so our approach is perfect together, but we see things uniquely sometimes, and because the brain is changing with any of the dementias, Mood is often the first change, other than short-term memory loss, that you will notice. That it's often due to the chemistry that's changing in the brain. And so some of the perseverating or the increased anxiety can also be a sign of depression. Depression can show up certainly with somebody wanting to isolate and stay in their room or stay in their bed and pull their covers over their head, but it can also be a sort of nervous wringing of the hands and an overly anxious personality. So if you're noticing that, that's a time to also speak to your doctor, because the first line of defense really in improving mood is to probably utilize one of the antidepressants that's available. So that is an easy, it's not a fix for the disease, but certainly an easy fix, or it can be an easy fix for some of the mood changes to rewrite the ship and put the ship more on an even keel.
Which agreed 100%, and you're talking about an enormous undertaking, because medication, the world of medication for things like anxiety or depression or psychiatric medications, or the kinds of medications that we'd start to turn to for these kinds of problems, anxiety and perseverating and changes of mood where the person is disengaged, that's a whole field in and of itself, and not all psychiatrists or primary care doctors are able to think in terms of what's going to be best for the person with dementia. And some of them can, as you say, the chemistry of the brain can be rather unpredictable. And so even starting a medication might at sometimes make the thing worse. And so I think one of your best tools is observation and starting to take notes, to make specific notes.
Yeah.
That certain times of the day the person seems quite anxious, or the number of times a day that they feel anxious, or if it's connected with some particular behavior or association or whatever it might be, as many notes as possible. And we're going to talk a little bit more about using a log in a few minutes.
So when is behavior a problem?
Right. So I think our data says that behavior is a problem when it's a problem for the person and when it's a problem for the caregiver, right? So it's a problem because you say it's a problem because you're endangering, one of you is getting endangered in the process. Right?
Yeah, and it can be when the caregiver can no longer tolerate the behavior. As we said before, your family member can only stay home as long as you're able to provide that care. And if you can no longer tolerate the problem and you are losing your own perspective and identity and health, then we have to figure out a solution for that. In most cases, we can't really change a behavior, but we can manage it. So.
Agreed. Not too much to add there.
Next page.
Yeah. So let's talk about some of the things that you can do as a caregiver. So we're not used to this relationship. We're not used to often in these relationships having to take standing in a new place in the relationship, standing in a place where you are managing parts of the household or part of the relationship that you're not used to. But one of the best things that you can start to do is to anticipate what might happen as a result of a particular holiday time or a change in season or a guest coming or a change in food, or having an ability to anticipate is one of your best tools as a caregiver. The person with dementia is going to go on the path the way they are, adapting as much as they can to the reduced abilities. And it's your job as the caregiver, if possible, to try to anticipate where those needs might take you, what might happen.
So in the segment on communication, we talked about the importance of listening and listening to the entire language of the body rather than just the words that are spoken. And we introduced this segment today to say that, once again, all behaviors are a form of communication. So if you're witnessing a behavior that is a little bit perplexing to you, what is your family member trying to tell you? And that, we're like Sherlock Holmes here. We're all trying to drill down and figure out, could it be this? Could it be that? So if you get used to looking at your family member in a new way rather than in the paradigm of your old relationship, sometimes that helps you figure things out a little more.
I think the other thing that people are not used to doing, and I'm going to make a suggestion that you try something really different, and that is to consider how you as the caregiver, you, the other person in the household, might actually be contributing to the behavior that you're seeing. So if the behavior has to do with their being having anxiety or whatever it is, you might start to think about what it is that you're doing that's creating that, and just as you consider what you can do to alleviate that as well. So, yeah.
So some of the more common behaviors, and again, these are not necessarily across the board, but they're more common in dementia than some of the delusional or hallucinations that can be very difficult to deal with. So the first one is called shadowing, and that is literally when your family member feels unsafe being apart from you. And again, if you look at all of these behaviors as again, form of communication that they're not feeling safe. Why are they not feeling safe? They're not feeling safe because their lack of memory is causing them to disconnect from the world around them. And so you, as the caregiver, become the point or the access for which they can function. And so shadowing is something that can occur. And also, not a lot you can do about it.
Except comfort them, maybe.
Yeah.
And say, oh, here you are. Here you are again. I was wondering how long it would take you to come.
Yeah, it can get
Here you
severe,
are.
though, where people, last segment we said if the repetition is getting too much, say, excuse me, I have to go to the bathroom. In shadowing, there are people that can't even do that. They can't have the door closed. So, it can get severe, but we'll go to the next one, which is sundowning.
Sure. Okay. So sundowning, in case people don't understand what that means and the history of it, sundowning was a term that was coined, I think, in the early days of dementia, where in nursing homes mostly, where in most nursing homes, shift change is about 3 or 4 o'clock in the afternoon, and people started to notice that this population of dementia patients became particularly agitated and frustrated and anxious right around the late afternoon, especially in New England where it starts to get dark, and people, I want to say that having dementia is incredibly exhausting for someone. And so if they've been at it for a couple of hours, even if they get up late, come late afternoon, people are really tired of trying to figure out where they are and what they're supposed to be doing and how to deal with their anxiety and whatever the question is that they've focused on round and round and round. And so in the nursing home, the nursing staff coined the term sundowning because it seemed to happen right around the time that the sun was going down. I think it has more to do with shift change than it does with the actual sun going down, but it's a good reminder for us that there's a separation between daytime and nighttime in terms of your routine, and that this set of presentations might appear at this time of day, and they're actually quite specific. It's a more agitated, a more jagged kind of impatience with whatever it is that they're feeling. So it's not a joyous feeling in any way, and it's so much more than just being anxiety. I think it has a more negative.
Yeah, it's a again more common than shadowing, I should say, but it can start as early as 2 o'clock in the afternoon, and as Alan said, often occurs because the individual just is so tired of trying to reground every 5 minutes. Okay, here I am, this is my house, this is my spouse, this is my parent, parent, I should say, adult child. Though they're often looking for their parent because they forget that their parent may have passed. But it also, so it can start as early as 2 o'clock in the afternoon. Generally somewhere between 2 and 4 is the witching hour. And if it's not relieved, the energy spiral becomes more intense as the evening hours go, and that person just can't even sleep at night, and that then becomes a problem because their clock starts to become disoriented. So exhausting behavior from just trying to ground during the course of the day. Also, as daylight changes from evening light, different shadows are created and things look different, and so they become disoriented. And the third point about sundowning is that, as Alan pointed out, we have a routine, and for many people that routine revolved either around working and at the end of the day you go home, or if you were in the house and at the end of the day your children came home from school, you were waiting for them to come home and you would prepare the dinner. So this is often the time where caregivers call us and say, they talk about a behavior, they don't define it as sundowning because they don't yet know what it is, but it is often the time when you begin to hear that refrain, I want to go home, I want to go home, or where's my parent, or someone's worried about me. So again, reassurance is really important. If it becomes severe, there's, again, medication that can modify the behavior, not change it totally, but can take them down a notch just so that they don't begin to spiral out of control. So, it's worth talking to your doctor about that. And what you would want to do is probably give that medication just before the anxiety is beginning. So perhaps somewhere between 2 and 4 o'clock, and maybe once again at bedtime.
I think there's some other things that people can try. Also, if you notice that the sundowning is getting worse, or if you're having a particularly bad day with sundowning, if you think about sundowning as being out of gas, that they're tired, they're tired of problem solving, they're tired of trying to figure out where they fit in the world. I think increasing the direction with them, so making some suggestions, giving them a particular project, having them do a task that's, albeit repetition or repetitive, maybe even having a little snack time at that point, changing the routine, sort of stopping whatever's happening in the household and addressing the person and what they're doing, and maybe having a little talk with them and find out, what they're saying. And they might be saying all sorts of sort of abstract ideas. You might not be able to make a lot of sense out of what it is that they're talking about, but the act of listening to them and stopping your day and checking in with them and having a little tea or a little, a little nutrition, something to get their blood sugar back up. That might be going on at the same time. They could be hungry or cranky and fussy in that regard. So for some people, taking a little nap is not a bad idea. But the problem is that if you let that, if you always go to that solution, they're going to get used to going to bed at that time. And if you let people with dementia sleep during the day too much, they're not going to sleep at night, and pretty soon night will become day and day will become night, and that's kind of a nightmare you want to avoid in dementia. So by all means, a rest perhaps, or
some form of behavior modification. Stealing, which again is a common behavior but is not stealing. When we look at stealing, we think of somebody taking something that is clearly not theirs, either from a household or from a store, and putting it in their pocket. You may find, particularly if you grocery shop with your family member, that suddenly you come to the checkout counter and there is a boatload of candy that you didn't put in there that they just felt they needed. So these kinds of things, certainly in facility settings, assisted livings, and skilled nursing settings, people wander in and out of other people's rooms and see something bright and shiny and they think it's theirs and they pocket it. So, please just be forgiving on that. Conversely, hoarding.
Yeah, it sort of goes hand in glove. It's a similar kind of behavior, but it's so common that it warrants addressing, because for so many people with dementia, hoarding becomes, it's thought to be an expression of loss in the greater population in general. And so who's losing more than people with dementia? That people with dementia are losing their daily activities and their memory and their connection with people. And hoarding is just a holding back, not being able to let go of things, continuing to
It helps them feel safe.
Yep.
So the more
surround
things you
themselves
have
with stuff.
on your body, you can open someone's purse and there'll be everything under the sun, including butter and silverware and
Right.
sugar, and it just helps someone feel safe. And then paranoia.
So paranoia is a false belief. Paranoia is believing something that's not really true. But for them, if you just tell them, oh, that's not true, that doesn't satisfy them. So it's a feeling more than a reality. And people who can't really make sense of the world in ways start to worry about how the world works, and they start to fill in blanks where they seem to be missing for the person in an attempt to make sense out of the world. And that, of course, is not completely effective, and people start to get not beyond anxious, they start to get paranoid. They start to tell the story, fill in the blank of the story, how things are. So why is it that we're home here now in this place? And so they'll have some paranoid thinking and think, well, I think a really wonderful classic example of this is when most people have to leave the house occasionally, and people will go to the grocery store and leave their loved one at home. And because the passage of time is so different for people with dementia, they're not able to really know how long you've been gone. They certainly think that it's longer than you actually have been gone. But the story goes that you're out and go to the grocery store and you're gone for a total of 20 minutes, but during that 20 minutes, the person with dementia has no idea where you are. They've forgotten what the story is that you told them. This happens with some regularity, so they start making up a story or become paranoid that you're never coming back, or that you're having some kind of affair somehow, that you certainly must be having an affair since you've been gone all day when it's really only been 20 minutes. So
I would say the affair, and I'm glad you brought that up, because that is really actually very common. The perception of your family member to believe that you're having an affair, regardless of your age. And why is it an affair? Because an affair is the ultimate form of abandonment. And as we've pointed out multiple times and will continue to point out, the person who has the dementia does not feel safe. And so if you're going to abandon them, how will they function in the world? And in that moment, if you are being accused of having an affair, just, gently remind the person how much you love them, give them a hug, say you can't live without them, do some reassurance, but certainly don't take it personally. That's really the story behind it, is the abandonment.
I think something that I've learned from several patients in my own experience with my mom who had dementia, introducing a dementia clock can be very helpful for people. It has a time limit, but a dementia clock is a large clock that displays the time and the time of day that it is. So it says, 2:10 in the early afternoon on Wednesday, November 1st. It goes into great detail, so the person can continue to look at the dementia clock and get oriented. It helps in some ways, but it's not going to be a permanent solution to the idea that it's the passage of time that they can't really experience.
You mentioned that in the communication segment, and in the same vein, I did mention using a whiteboard. And it's good to bring that up again in case you're not watching this in sequence, but having a whiteboard, certainly not as big as what's behind us, but where you can leave a note, and that as your family member is anxious and wondering where you are, can continually walk back to the whiteboard and see, I'm at the store, or I'll be back at a certain time.
I do think it warrants saying, though, that notes and whiteboards have a lifespan too. That too expires, and the person no longer bothers to look at what the note says, or no longer has the ability to problem solve at all, and just sits and worries and laments over.
Which, again, is the main reason why we are concerned when someone is left alone. And, certainly it's safety, but more so because the emotional distress and the emotional pain that the distress brings about takes so long to de-escalate that finding another solution so that you as the caregiver have the freedom to go out is really important to recognize.
And tough, and to the point where it's very difficult for caregivers to finally admit that they actually should not leave their loved one at home alone and need to be replaced by another person, using a home health agency or a relative, or making a schedule where people can come in and just sit with the person so that there's another person, another human in the room. It's really hard for people to admit that you can't leave your loved one at home. So let's talk about some of the triggers, some of the things that trigger some of the behaviors that we're talking about. I'll just start with, so the behavior is triggered often by the environment. Let's just think about what's in the environment.
Can I just stop for a minute and say that a few minutes before we said you almost have to be a Sherlock Holmes or a sleuth to figure out what the behavior is communicating. So these are common triggers, or a way for you as the caregiver to think about, okay, is it the environment?
So is what they're experiencing something, does it have something to do with the environment? Is it Christmas time? Is it summertime? Is it too hot in the room? Does the person, is there too much noise that's distracting them? Is it too cold? Are there too many people around? Do they not have, what's going on in the environment that might cause them to be distressed in some ways?
Yeah. Or did you go away for the weekend?
Yeah.
Or,
Are they hungry? Are they thirsty? Are they just so many things that they probably cannot even identify any longer?
So if the answer in your mind, after you've asked yourself that question, is no, nothing in the environment has changed, you go to the next question. Is the behavior triggered by communication? So meaning, is it something that you said? or someone said to them that they're struggling with?
It's hard there too, because I think that sometimes people imagine other people in the room, or they imagine other people in your lives still that are no longer there. So sometimes a person has a hard time distinguishing between a daydream that they had, or an imagination that they had, or a television show that they've been watching, and what's really true. And so when you're thinking about the communication that you've been having with the person, sometimes they're communicating with the television as well, or they're communicating with the past in their mind's eye, and they bring that into the reality of today. And so it's a little bit difficult for you to have an argument about something that's happened in their head, because you don't really know what that is. And so you can make some queries. You can sort of ask about, who they've been talking to lately, or what they've been thinking about lately.
Or just say, oh, that's really interesting.
Or don't
because
know it's
remember, as we pointed out in the communication segment, they're always going to be right. So don't bother to
Absolutely,
argue.
yeah.
It's not a fight that needs to take place. And then the next, so if not the environment, not communication, the third one is it a task? Did I ask them to do something and it was too difficult for them to do? So that could be, perhaps they've tinkered with things in the house all their life, and now they've taken apart the lamp and can't put it back together. Or is it that you ask them to set the table and they can't figure out where the plates and the silverware go, and then they become frustrated? Or if they were a musician and played the piano, and now you've asked them to, just because you were looking for something for them to do, you asked them to sit and play a song on the piano, and now they go to put their hands on the keys and they get completely frustrated. So it could be that there's a task involved, that you ask them to do something that they're no longer capable of doing. They become frustrated. They don't know how to channel that frustration anymore, and it comes out as behavior.
So, I'm imagining hearing all this, and that it's so much information to take in. But I guess you can come back and watch the tape a few times, or take some notes or something. But this one in particular, I think is a helpful review, the task, because I think it's helpful if you ask yourself about the person with dementia. Have they been engaging with some tools, some technology, something that involves a lot of rules or steps that they can no longer, they no longer have the capacity to use the tools, or to follow the steps or whatever. And it'll be really helpful if you can just stop long enough to think about, is this something now that is beyond their capacity? And you can just alleviate the whole thing by saying, oh, I'm going to do this, and why don't you drink the tea, and we'll work on this together, and you just take it over for them, so they don't feel badly about it. And then there's health. What about the health?
So if there is a change in behavior that has lasted more than 48 hours and is a noticeable change from their baseline level of confusion, generally it's a health issue. And so it's very important, and all of you, I'm sure, are hyper aware of your family members' baseline level of confusion, and that changes as the months go by, but that doesn't generally change from day to day. So if you suddenly notice an increase in agitation or anxiety or lethargy, then it is often a urinary tract infection or some other metabolic problem going on that needs more identification.
So I'm going to give you some examples of those. So quite often, and a good list to go down would be to think about, the simplest first. Are they just too tired and cranky to do the thing that they would normally be able to do? They're having a bad day. Do they need to go to the bathroom and they don't realize that they can go to the bathroom, that it's okay for them to get up and go to the bathroom because, maybe they don't know where the bathroom is, or you're visiting somewhere or whatever. So it might be bathroom needs, or they may have had an accident and they don't know how to admit to that. It might be related to medication that they're taking. So you want to think about, would a Tylenol help? Because oftentimes a couple of Tylenol is like this magic drug, if you're allowed to take Tylenol, to bring down some feverish kinds of symptoms and to help them to relax a little bit and to alleviate the pain that they're feeling, but they can't really identify where the pain is. Tylenol is fabulous. Are they hungry? Are they thirsty? Are they in the habit of not drinking as much as they used to, and so as a result have become dehydrated? This happens so often in elders who will always decline to have a drink. If you bring them a glass of water and say, or you say, would you like to have something to drink? They'll always say no, because they're so afraid that they're going to have bathroom issues. But if you take 2 glasses and pour a glass of juice in each glass and bring it to them and say, I'm having cranberry juice and this one is for you, they'll take it right down and drink it. So there are little techniques that you can use to make sure that people don't become dehydrated, because they're often dehydrated, and dehydration in an elder looks quite painful. It looks quite distressing, and is definitely a health concern that goes right along with, I think, constipation is another one that people don't know that they're constipated when they're constipated, and it feels terrible.
As a nurse, drinking fluid is logical in thinking about hydration, but if your family member doesn't want to drink, even if you are pouring 2 glasses and you're having one alongside of them, you can also use Jell-O, you can use popsicles, you can use soup, you can
yogurt,
use watermelon. There's a lot of different foods and methods of getting fluid into the body other than just a simple glass of juice or water. So again, we're happy to answer your questions on a phone call. And if you're listening to this and you're resonating but you're not certain, and you don't want to call your physician, certainly, these are solutions that we can help with. So
I'm going right on to
Okay.
the physical problems that can contribute to agitation. So we've got a list.
Yep.
I'm not sure that they need to have an explanation, all of them, but they're worth mentioning, that certainly medication interactions can
Yep.
be a precipitating factor to having behavioral changes. So all of a sudden they're on a new medication and they are sleeping a lot, or not sleeping at all, or are agitated, or are fill in the blank. So medication. Should we just go back and forth?
Pain and physical discomfort, and as Alan mentioned, Tylenol is terrific for that. But if you ask and you say, are you in pain, you're always going to get no.
Oh, no.
So this is where you have to visually observe somebody's physical stance. And, if they're sitting in a chair like this, you can be certain that their neck or shoulder or some body part is going to hurt. So use your common sense. A lot of this is common sense.
I do think that it helps. Now, this is in more advanced care. Obviously, we're talking asking the question, are they in pain, isn't as beneficial as actually checking to see if they might actually be in pain, that their underwear isn't twisted, or they're not sitting on, some terrible askew, cushion that's askew, or a very uncomfortable chair, or whatever it may be, really to physically check, because they're not going to be a good reporter of whether or not they're in pain. So there's that. And I'll just go on to fatigue and lack of sleep. People are cranky. Kids are cranky if they don't get enough sleep. And it isn't just lying in the bed sleep. Lots of people with dementia will lie in the bed for a long time because they feel safe in bed, and because it's not hard to be in bed. It's a safe place and it's a quiet place, and they like to spend a lot of time in bed, but they're not necessarily getting good quality restorative sleep. And so you have to kind of determine whether or not are they tired, are they cranky because they're not getting enough sleep. So there's that.
We talked a little bit about dehydration, also malnutrition, people not eating enough. And I don't want to, I'm not a stockholder in Boost or Ensure or anything like that, but I do want to mention that it is a complete meal. And if you are concerned that your family member is not eating enough, you can kill two birds with one stone and get liquid and nutrition into them in the form of using a powered drink like that. Or, nowadays there are also a number of really good electrolyte hydrating liquids that also have protein in them. One that I bought for myself called Trimino, which is for athletes, but it has a great taste and it's not overly sweet like Gatorade. So, think beyond the box here. We're sort of conditioned to think that if you sit down at the table and can eat 3 squares a day, that you are doing just fine. But eating a meal requires a lot of concentration. And for people with dementia, it can be overwhelming. And that's a whole other subject. So if you're concerned or you're noticing weight loss, think beyond the box. I want to do a little bit on dental hygiene, if you don't mind.
Sure, no problem.
I also know that, and again, this is from my nursing background, that's why I wanted to take this subject, that for most caregivers, dental hygiene is the one thing they leave behind because they're so grateful they can finally shower their family member and dress them that they say, okay, if they don't want to brush their teeth, fine. But the oral cavity is the first place where infection can enter the body. And so somehow try, even if it's a little baking soda and water rinse, just to help neutralize the acids in the mouth, that, and maybe a little parallel play, if you will, of you and your family member brushing your teeth together. If you can, maybe a electric toothbrush, a water pick, anything, again, thinking outside the box, because it is an important part of hygiene and health.
Can I say something perhaps a little bit amusing? So I don't know how it came to pass, but my mom, so I took care of my mom who had Alzheimer's until she passed last year, and my mom, she was 90 years old, and I think my mom never understood that I knew that she had dentures. She had dentures for a long time, and she never knew that I knew that she had dentures. And so I noticed that her dental care was not what it should be. And I didn't really know what proper dental care looked like for dentures. So I had to do a little bit of research to intervene. And so that speaks to our, exploring a little bit more information than maybe we would have. And I found myself bringing her to the dentist, which was really remarkable. The dentist was so pleased to be able to check her oral cavity and to say, oh, she's in very good health and the dentures fit well and the care is fine. And so I was pleased, but it was because it was on one of these lists at one point. I definitely boosted up my understanding of her dental care, and I think it was to our credit that we did that.
But here again, so on the final list here, we have poor sensory input can be a common medical trigger. And I have a couple of things I want to say about this, in particular, vision. So we've alluded that people can perceive things that are not there, or make up stories about things that have not really happened. And with vision, the family member will often say, let's get your eyesight checked, and they will go to great lengths, bring to the optometrist, ophthalmologist, get the eyes checked. The glasses are fine, maybe needs a little tweak. They come home, get the new glasses on, suddenly, nope, can't see anything. I'm still seeing those, people over there. The family can go back and forth with this, not understanding that has nothing to do with the glasses. It has everything, and the same with hearing. It's the brain's ability to transmit the signal, which is deteriorating because the disease is progressing. So understanding that and having that knowledge base and the confidence to have that knowledge base and not run yourself ragged back and forth to the doctor trying to solve this problem is important.
I wanted to add one more thing. The benefit of being a facilitator of support groups is you hear a lot of stories about what people with dementia are experiencing. And as an example, just to dovetail on what you're saying about people seeing things or not seeing things, I want to support absolutely that the brain is having a really hard time understanding the signals from the taste buds, from the ears, from the eyes. And the brain is having a really hard time putting things together and making sense out of them any longer. And one example of that had nothing to do with hearing aids or glasses or any of it. The person with dementia, in this particular case, was highly irritated by this person that would completely randomly appear in her life, constantly appear, this person that she didn't really recognize at all anymore. She didn't understand who this person was, even to the point where at one point the caregiver said that they were driving in the car and the person was following them in the car, and he became quite concerned. Well, of course, what was happening is that the person was seeing their reflection of themselves, who they no longer recognized as an older woman or looking like that, and even in the rearview mirror would see herself looking at her.
Oh my goodness.
And would see her reflection in the windows at certain light when the light would come, or in the bathroom when she would look in the mirror. That was not her. So she had this woman that would follow her around. And that's not the only person that I've heard that.
No, I likewise.
So it's fascinating to think that the brain is like
there are so many stories we have.
Yeah.
One gentleman said he now has to put a curtain over the mirror in the bathroom because his wife believed someone was watching her take a shower.
You can go on all day, probably.
Yeah.
Example is interesting.
I want to talk a little bit. We're dealing with. We're moving into the realm now of agitation and aggression and combative behavior, and so I often use, and it's not in here, which is why I wanted to start with this. I often use a trajectory where someone becomes anxious, and if that anxiety is not quelled, it becomes agitation. And if the agitation is not quelled, it will then take its course. It's like a spring getting tighter and tighter and tighter. The individual will become combative. And why are they becoming combative? Because they are perceiving an external threat, whether it's you or somebody else, or a perception in their environment that they need to protect themselves to survive. And so this as a caregiver, it's important to recognize anxiety, agitation, combativeness is a continuum. Thank you. So do your best to deal with the anxiety. It's far easier to deal with anxiety than it is to deal with combative behavior.
And there are some steps to take. It warrants saying there are some steps that you can take in advance that you may not be thinking about to protect yourself and other people in case it gets to the point where the behavior gets too combative. And a lot of those have to do with prevention. And I'm just going to mention a few because people don't think about them. But if you have firearms in the house, 40% of American homes have firearms. If there's dementia in the house, then the firearms either need to be removed or need to be re-secured in a way with extra trigger locks or put in a new place, etc., so they're not accessible. That goes right along with so many other things like big knives in the kitchen or dangerous kinds of things. You know what's just like a firearm? An automobile, getting in behind the wheel of a car. Another thing that's very, very dangerous is a snowblower that the person hasn't used in 9 months and then all of a sudden goes out to, well-intended to use the snowblower and sticks their hand in the snowblower. Forgets about those kinds of things. Or an electric saw where they may have been quite skilled at, building things and using saws, now is not taking the precaution, So you have to really step back a little bit and think about what are the dangerous things that are in your home that probably should start to be removed and or secured so there's just that. Nobody says that enough, so I just want to put a little in there.
So when your if you're not able to quell that anxiety and they become aggressive, they start becoming super agitated and accusatory and aggressive. Don't take it as an attack on you personally, but ask yourself, can I realistically handle this situation in this moment? Am I physically capable of diffusing this? Because it is now beginning to spiral out of control, and it doesn't matter that you've been married to this individual for years or that this person is your parent. Right now, in this moment, it's a task of survival of the wills. And so ask yourself, can I realistically manage this situation? And if the answer is no, then the next is what we're going to tell you to do, which is to call 911. And people are really concerned about calling 911. They think all kinds of things are going to happen. All of the police and fire department are, they have been trained for years now in dementia. And so if you call and you say, my family member has dementia and I need somebody to come over and de-escalate the situation, they get it. They absolutely get it. And often just by coming to the door with their uniform, sometimes the situation has already been diffused, but if it hasn't, just by virtue of having another person there who looks like an authority or is an authority, it will take things down a notch so you can rethink what's going on.
Yeah, that's beautiful because it is, of course, assuming that you've secured the area first, get yourself out of trouble, back away from the person, give them a little bit of space, do a little work ahead of time to make sure that these weapons and things are not accessible. But Suzanne puts it so well to say, there's nothing like, and we've done this training for years now with first responders. They actually really like showing up at dementia homes because it's a place where they can have a real impact on people to help them get up from the floor, or a sort of a simple thing for them, but it's a really difficult situation to handle. Suzanne puts it so well. There's nothing like a guy that shows up with a big hat and a gun and a uniform to deflate the whole view. Oh, there's nothing wrong here. So that's really great.
Yeah. They will, if they sense that there's something going on that needs more attention than just a quick diffusion, they'll ask you if you want them to take your family member to the hospital. And that's for you to decide at that moment how safe you feel. And if you think that if this is a situation that's happened repeatedly and you finally have the courage to call 911, it may actually be the time where you ask them to take your family member to the emergency room so that they can have a complete medical workup and see what's going on.
Good.
Yeah. Okay.
Great.
So.
So we're going to talk about, so overall we're talking about strategies for coping, but we're going to talk about frustration specifically and how we get frustrated. And that is a common thing that we do all the time, get frustrated around people with dementia because we love them and we don't know how to make them feel better. We just don't, unless we put some thought into it, we don't know how to take the dementia away. And we can take the dementia away, but here's some things that we can do. So I think it's important in minimizing the frustration that people with dementia feel or that we feel by looking at their body language and looking at how you are in relation to them. Like Suzanne and I are sitting not face to face, so it's a little less confrontive, if you will. If we're sitting face to face, it's a little bit more confrontational. Looking at people's body language, you can tell when a person, even if they don't have language abilities any longer, or what they're saying can't necessarily be trusted, you can read their body language and know that they're agitated and frustrated and about to strike. And so you have to kind of stop and think, okay, what is going on with this person? So you really have to look them over and have a willingness, if you will, to go a long way in helping them to understand the original, what got them to this terrible place.
A lot of what I'm looking at the list here, and a lot of these things we talked about in the communication segment and earlier in the behavioral segment. There's one thing here, keep it simple. And I actually had a phone call this morning, and I think it's appropriate to just say, certainly, so this adult child whose mother is now in an assisted living, and so when she goes to see the mother, the first 4 minutes are pleasant and loving, and I'm so glad to see you, or how come you never come to see me, even though she comes every day. So I'm relating this story because it's so common, and then suddenly the mother shifts and now becomes accusatory to the daughter. And why am I living here? I hate you, and etc. So the daughter called because she's upset. She loves her mother and she wants to have a pleasant visit. So the question is that even possible? Given that the mother is now living in an altered reality state with her dementia. As I said, okay, so tell me, how does the visit go? And she said the first 4 minutes, pleasant. By the time we get to minute number 5, she starts with the accusation. So I said, okay, make the visit short. If you want to go, you're only going for 5 minutes. You can't change your mother's perception. But what you can do is begin to set some boundaries and say to your mother, if you can't be nice to me, I have to leave. And if the mother continues, then you leave. And so you begin to set up a new paradigm of behavior through repetition. And hopefully over time that will work. It may not. I said to the daughter, it may not work, and you may have to live with it and come to group and release your emotion there about how painful it is to see your mother. I mean, literally, all of you are losing your family members in front of you, little by little. And this is probably the most painful thing about this disease is, whether it's behaviors or communication or all of it, there's nothing you can do to stop it. And it's really important to get support for you so that you can move through the trajectory of this disease alongside of your family member without losing who you are.
So I'm going to, and I just want to interject that. So this is a really good example of how being in one of our support groups is really very helpful. It's critical, I would argue, that over time you're going to hear many different scenarios, just like Suzanne described, and your solution, your attempt to help her was right on, fantastic, and I would suggest something entirely different as well. So another thing that I want to just emphasize is that in addition to, so this is all just around coping with a person with dementia, that in a visit like that, or in interacting with the person with dementia, I would argue that sitting down and having a long, extended conversation beyond 4 or 5 minutes is probably not ever going to go well, because the person is going to begin to drift. And so it would be so much more helpful if in that visit or in your day-to-day interactions with the person, you had a common goal, you had some things that you were both jointly doing, or that you had a task at hand, and that the person could focus on something other than, they're no longer home, or their inability to express their frustration or love for their daughter, or whatever the story might be. They can focus on the task a little bit. And so I would say to keep things as simple as possible, to try to focus on one thing at a time, to try to keep that routine that we spoke of earlier, the routine being supreme. That having a short visit is a great solution to that. Get out while the getting's good. Keep it positive and leave the room. Yep. Or focus on, folding towels or doing any kind of thing that would be a distraction to the inevitable feelings of despair that the person is going to come to.
Frequently when people, that's excellent. But when you're visiting somebody, and many of our family members at a certain point in the disease, no longer can keep their family members safe at home, so they are moved to an environment where they can be safe, whether it's an assisted living or a skilled nursing environment. I always say, bring a prop.
Yep.
A prop.
Something.
So what is a prop? A prop could be a newspaper, a magazine, a cup of coffee, an ice cream, something, so that when you go to visit someone, let's say I was visiting Alan, and neither of us have dementia. Not sure that's not true, but neither of us have dementia. And I say, how are you?
What do you want to know for?
You see how this goes? So instead of asking the standard checklist of questions that we typically ask in a visit, say, oh, hi, I'm here to bring you the ice cream that you like, or the coffee. And even if you sit down with the newspaper and read the headline, or what's on sale at Stop and Shop, and remember that apple pie you used to make. Now we can go get the apples. It really changes the visit and makes a better quality visit than trying to go down the checklist.
You want to stay away from the abstract that the person with dementia will never be able to figure out a reason. Why did you put me in this place? Well, their memory will fail them, and they won't be able to remember how they failed at home. And it's all way too abstract. Bring it concrete. Tomatoes on sale at Stop and Shop.
Yeah. Want me to go get them?
Apples,
I'm leaving now.
Make an apple pie. Just here I am. I'm your daughter, and I love you, and it's springtime, and isn't it great? And stuff like that.
So.
Don't try to reason or argue, or it makes no sense any longer for the person with dementia to complete an argument.
But behavioral interventions take time, not only for your family member, but also for you. Your behavior has to change. You're the one that is going through the change. And so, You know, if you have looked at every situation upside down and sideways, and you're still seeing that there's a level of anxiety and agitation that you cannot safely manage in the home setting. And I want to make this point because I said the home setting, it's more frequent that people use behavioral medications as an adjunct in the home setting rather than in a facility setting, because in the home setting you're the only other person there caring for your family member. In a facility setting you have other staff members who can pitch in and help diffuse or relieve you if you get too tired. So if you need to use behavioral medications as an adjunct for care, it's something you want to talk to your doctor about. And there is a logical way to start. Now, Alan had suggested earlier on in the segment about using
Documentation. Write it down.
documentation, or a behavioral log. Nobody is going to just prescribe medication without understanding the rationale behind why they're prescribing the medication. If you say the person's anxious, okay, well, they need more information, so that's where the documentation is important. And it could be that what you're describing is sundowning. You didn't know the terminology, you didn't know this was common. Your doctor now understands why the person becomes anxious and what is the appropriate medication. If, for example, you're talking about the individual who's seeing their reflection in the mirror and you can't manage that by covering up the mirrors, and the delusional thought is spiraling out of control, that's a different form of medication that is utilized. So if it's a mood issue, again, another form of medication. So it's really important to understand what is the behavior that you're trying to modify with the medication, and that is an art form. It is truly, there's no magic pill. Every medication rebalances the brain chemistry in a certain way, and sometimes people need more than one medication to balance their brain. And also it's important to say, as the disease progresses, the need for medication may diminish or increase. It just depends on the person.
And then there's always this. People with dementia are elders. And what's the number one risk for elders in society in general? It's falling. And so any medication that gets added to the list will probably have some potential of increasing the person's risk factor for falling. If it's a sleeping medication and they get up in the middle of the night to go to the bathroom and they're a little woozy, they're more likely to fall at night. And so prescribing medication or administering medications has to be done very carefully with fall prevention in mind, because especially in an elder, medication can have quite a profound impact on their ability to balance.
And
sit up.
In the first segment, I talked about the most common trajectory for end of life in someone with dementia is precipitated by a fall.
Falling down.
Alan has repeatedly said in the communication segment and today, a routine is premier or supreme. And so someone falls, and someone falls, whether you're young or old, generally, particularly if you're older, the likelihood that you're going to fracture a hip or another bone is going to happen. You go to the emergency room, your routine is now changed. You are in pain. You are anxious because you don't know where you are. You know, all kinds of stimuli are coming at you. The physician needs to examine you and they medicate you, and or your family member. And you know, if you need surgery, unfortunately, anesthesia can further exacerbate the signs of dementia. You can get increased confusion, which is called a delirium, and that is no easy feat to try to manage. And more medication is then put on board to try to stabilize you. And the person that goes in prior to the fall and the person that comes out is a totally different individual.
Sometimes.
And in dementia, as the disease progresses, it's, you know, like a step down pattern, but no one ever goes back up to their baseline level of functioning. Wherever they end is their new baseline. So it can be an eye-opener that causes a lot of distress for you as a family member. Again, one where you probably need support.
So with that grim description, I think that what we're going to do is tell you a little bit more about what you can physically do, what you can do to help minimize the experimentation that goes on with medications and get you closer to an accurate prescription that will help the particular need. And that comes in the form of documentation. That's a behavior log. And we've mentioned it before, and I just want to say, by logging and describing what the behavior is that you've seen or that you see and what's happening, where are you, what's happening around the person, what is the person demonstrating, are they sleepy, are they agitated, are they anxious, are they falling down, are they whatever, and time, date, place, with some pattern, the physician is going to be able to look at that log and say, oh, okay, this has more to do with their neurological condition than with the behavioral problem, etc. And will help them get quicker to a solution.
Finding a solution, yeah. And, if the idea of a behavior log is daunting, just take a simple calendar. And, you can write great day. And if it's a bad day, put, a star, bad day, and maybe the timing, and, begin to drill down and use that, and just bring the whole calendar in with you to the physician's office. That way, again, they can more pinpoint and target a solution or a modification to what's going on than to just leave you hanging thinking that there's no help out there. So again, remember it's an art form, and it requires a lot of tweaking if you're going to use medication. People don't generally hit it right on the money the first time around. So just be patient and find support in groups. Call us if you are in need of extra counseling. If you haven't been enrolled in our program, certainly give us a call and we'll do a care planning with you, and all our services are free of charge. And we're here to help you, and thank you for watching the segment on behaviors.